Hello everyone, my name is Tomas Chavarria. I'm a third-year oral surgery resident in Universidad Internacional de Catalunya, Spain, and today I'm going to present this complete bimaxillary rehabilitation case with immediate loading. Well, let me present to you Jordi. He came to our department because he wanted something fixed and he no longer wants removable prosthesis. He's a 51-year-old patient with no medical history. He's a 3 to 5 cigarettes per day smoker with a dental history of periodontitis. Jordi without prosthesis in his maximum smile doesn't show any mucosa, which is very important for the future prosthesis that we're going to deliver. And with his prosthesis, we can see some static parameters that can be improved, but in first impression, we see that they're okay, the vertical dimension is good, so we're going to go ahead to use this prosthesis for the wax-up to planify our future implants. Here's an intraoral view of his mucosa, some cicatrization going on in the alveolar processes that we think is due to some recent extractions. In the OPG, we can see that there's some erratic healing, most probably due to this extraction with some inflammatory process in the apical. This can be seen in the mandible and also in the maxilla. Later on, we want to know the prosthetic space that we have for Jordi. We have in between 11.5 to 14 millimeters. And if we go to the literature, this is according to a pink and white aesthetic. So we have to think about an FP2 or an FP3 prosthesis. We want to do immediate loading, so we went ahead to see the last consensus of the EAO in 2021. And they established that for delayed implant placement with immediate loading, which is our case, the timing of the implant loading does not influence the survival of the implants in this kind of fixed dental prosthesis. But in relation to patient perception of this immediate loading, they had some evidence that demonstrate a higher patient satisfaction with immediate loading rather than early or delayed loading implants. So in this case, we're going to plan immediate loading with 6 implants in the maxilla and 6 implants in the mandible. Moving on to the implant planification, in the maxilla we can see that we have enough height and width of bone to place our implants, so we're going to go with the Straumann BLX 4x12, all of them, they're going to be straight, so our abutments are also going to be straight abutments. In relation to the mandible, we also have enough width and height of bone. Some of them are going to be 4x10 millimeters, and the others are going to be 3.5 by 12 millimeters. They're all going to have straight abutments. We decided to go for a guided approach in this case because we wanted to achieve emergence of the implants right where we wanted them. So in case of the maxilla, we're going to go ahead for 2 surgical guides. The first one is going to be a copy of his prosthesis with fixation pins, and the second one is going to have the fixation pins in the same position and the guided tube for the guided implant placement. In case of the mandible, the first one is going to be as the same one in maxilla, and the second and third are going to be osseous supported. The second is going to help us with the bone regularization, and the third one is going to help it with the implant placement. So moving on to the surgery, first step is to place the first surgical guide in maxilla and mandible, fixate everything. We go to the maxilla, we remove this first surgical guide, place our second one, fixation pins, and we go ahead to place our implants. You can see that the implants emergence is according to what we planified. And in case of the mandible, we remove this first surgical guide, we open our flap, we place our second surgical guide, and we start the bone regularization. In this case, we started with a Lindemann bore with a straight handpiece. This is to remove the big bone parts, and then we regularize everything with a round bore. This regularization is very important in order to achieve the bone at the level that we plan, because we have to remember that the implants are planned according to this new level of bone. Later on, we take out the second ferrula, we place our third ferrula, and you can see how easy it is to remove and to place the third one, because the base of the ferrula is exactly the same. So it's going to go in the same place of bone, and it's going to guide our implant drilling and our implant placement. Here you can see an OPG of the patient right after the surgery, where the implants and also the transepithelial are according to the planification. And the next day we go for the immediate loading. The laboratory sends us these PMMA provisionals, and we place it on mouth. We have to adjust some occlusal point, but everything is correct. In the occlusal photos, we can see that the implant emergence is correct and according to what we planned digitally. And in extraoral pictures, we can see that the parameters, aesthetic parameters, are correct, and they're even improved according to the previous prosthesis. Let's remember how the patient came. The patient came edentulous, completely edentulous, with occlusal stability, but removable. So it was not really an instability, and now he's stable with something fixed, very happy. And well, we have to remember that we are in a provisional phase, and later on we're waiting for the healing, and we want to deliver a final prosthesis in November or December from this year. So why do we wait for immediate loading? Well, as I said before, there's patient satisfaction, but there's also surgeon satisfaction. I think that we have to remember why we're in this field, and to see a patient so happy to receive a fixed prosthesis after not having something fixed for a long time is very rewarding. Also, the soft tissue healing, we can guide it with the provisionals the next day from the surgery, which is very good for the later prosthesis. And there are no differences in implant survival rate or marginal bone loss. So I think the final question is, if we can, then why not do immediate loading? Finally, I want to thank everyone involved in this case: Valentina, my prosto partner, Dr. Paul Tuna and Federico Hernandez Alfaro, head of the surgery department out of my master, which helped me a lot in this case, and Dr. Mitchell Chavez from the rehabilitation department that also helped in this case. Thank you.